Good evening and welcome to the first journal club of the year. Yeah. Welcome to the first journal club of the year, where we're going to have Tim Clough and Chris Blundell discuss possibilities for joint replacement in hallux rigidus. So Chris has actually very kindly joined us from his retirement home in Germany to discuss his paper on Cartiva. And Tim Clough will be discussing his paper on silastic implants and follow-up. The evening will take the course of a registrar fellow presenting the paper briefly, and then Chris will discuss his paper and the reasons for it and the rationale behind designing the study. Then Tim Clough's paper will be discussed by the fellow. Tim will make some comments, and then at the end, any questions from the audience we can put to Chris and Tim, and we can have a live discussion about the merits of metatarsal joint replacement and the possibilities we have. So with no further ado, I'm going to pass over to the video explaining Chris's paper, followed by a discussion with Chris. Thank you.
Good evening, and thank you for the opportunity to discuss Mr. Blundell's paper on mid-term outcomes of a synthetic cartilage implant for the first MTP joint in advanced hallux rigidus. In terms of background, in 2016, the Cartiva Motion Study Group published the results of their prospective multi-centre RCT looking at Cartiva versus arthrodesis in hallux rigidus. This included 12 centres in Canada and the UK, and with a 2-to-1 randomisation, they enrolled 152 patients to the Cartiva arm and 50 to a fusion arm, and they followed them up to 24 months. These included patients with grade 2 to 4 hallux rigidus, and 2 training patients were allowed for each investigator starting the procedure, and the results of these learning curve patients were not included in the trial. This study demonstrated statistically equivalent pain relief and functional outcomes in terms of VAS and foot and ankle ability measure, and it also demonstrated a 6.2 degree improvement in dorsiflexion with Cartiva, which was maintained at 24 months. They also showed similar rates of secondary surgery, with 11.2% of Cartiva patients undergoing further surgery and 12% of fusion patients, although it is notable that the fusion patient secondary surgery tended to be smaller removal of metalwork type procedures. There have also been some further publications based on the same patient cohort. In 2017, Goldberg et al. Examined patient factors within the same cohort to look for any bias or association of baseline factors which may have affected functional outcome. They found that there was no statistically significant difference between Cartiva and fusion when patients were stratified for hallux rigidus grade, gender, BMI, age, symptom duration, pre-op FAS scores, and whether they or not they'd had prior MTP surgery, hallux valgus, and what their pre-op range of motion was. Glazebrook et al. Subsequently looked at the operative data as well as the early scores, and they found that there was a significantly shorter operative duration, anaesthesia duration, and a faster post-op improvement in functional scores with Cartiva. So in terms of that, recognising that many hemiarthroplasty and total toe implants over the years have demonstrated initially good results that deteriorate with time, the authors of this paper wanted to find out if the results of Cartiva at 2 years were maintained at more than 5 years. They also wanted to look at implant survival. They hypothesised that the overall rate of conversion to arthrodesis from 2 to 5 years should be non-inferior to the extrapolated rate if you assume that the same exponential removal rate observed in the first 24 months as per the original paper. They plan to look at 3 main areas of outcomes: firstly, implant survival, secondly, PROMs, and thirdly, safety data. So the patients included in the study had undergone Cartiva between November 09 and February 13 as part of the original RCT, using a standardised operative technique described in that paper. This led to 135 eligible patients. Of these, the device status was known at 60 plus months in 119 patients, enabling these to be analysed for survivorship. 112 enrolled in the 5-year follow-up study. There was 1 death, 17 loss to follow-up, and 5 declines. And these 112 were thus able to be examined for adverse events. Of these, 6 patients had device removal prior to 16 months, leaving 106 patients who were examined for clinical outcomes. The authors looked at implant survivorship at 5 years. They did a pre-study statistical analysis confirming that it was sufficiently powered to reject the null hypothesis that implant removal rate between 2 to 5 years should be the same as 0 to 2 years. They also looked at safety in terms of revision, removal, reoperation, displacement and fragmentation. This included physical examination, looking at range of motion measured with a goniometer, as well as weight-bearing x-rays to look at implant position, cysts, any AVN and heterotopic ossification. Furthermore, they also collected outcome scores. These included the VAS score, as well as the foot and ankle ability measure, ADL, and sports scores. So in terms of results, firstly looking at survivorship and safety. During the first 24 months of this study, 14 of 152 had been converted to arthrodesis, which is 9.2%. Between years 2 and 5, 9 further patients converted to arthrodesis. This meant that they were able to reject the null hypothesis, which was that there would be inferior removal rates from years 2 to 5 versus the first 2 years. And this is the case even when unknown patients were defined as failures through a tipping point analysis. Of the Cartivas that were removed, 8 out of 9 were removed due to pain, and they were successfully converted to fusion with no additional complications. 1 of 9 was removed due to a Staph aureus low-grade infection. They performed a retrieval analysis of these patients, and this demonstrated only minimal wear in 2 of 9. The overall Kaplan-Meier survivorship was therefore 84.9% at 5.8 years follow-up. In terms of safety, no patient underwent reoperation for any reasons other than for implant removal and fusion. Radiographs for 97 patients at 5 years were assessed by an independent radiologist who found no evidence of AVN device migration or fragmentation. There were some bony reactions noted on the X-ray, as you can see in the table. These did not significantly change between the 2 years and the 5.8 years, and there was no correlation between bony reactions and rate of conversion to fusion or functional outcome scores. Looking at the results in terms of functional outcome, this graph looks at the VAS and FAAM scores pre-op versus 2 years and at 5.8 years. As you can see, the improvements in scores at 2 years are all well maintained at 5.8 years. 56.2% of patients strongly agreed and 31.4% agreed that they had an improvement in overall well-being at 5.8 years, and 93.4% would have the procedure again. This is a graph looking at range of motion at the baseline 2 years and 5.8 years, and as you can see, the pre-op range of motion is well maintained at 5 years when compared with baseline in 2 years. Although there is a slight drop compared to 2 years, it was not statistically significant. So what are the strengths of this study? Well, it's the largest and longest term follow-up of Cartiva in publication to date, and given that it is a prospective multi-centre study of many surgeons in UK and Canada, there is good external validity and the results are generalisable to a broad group. A robust statistical analysis was performed and validated outcome measures were used, and the improvements all met the minimum criteria for difference. In terms of limitations, the authors did note that there was a lack of outcome data on the control group of arthrodesis patients. Would they also have had a similar maintenance of functional outcome? Well, other studies have suggested that they would. A recent study published by O et al. Suggests that Cartiva patients had superior PROMIS scores at a mean of 33 months compared to arthrodesis patients. The results in the literature have been a little bit mixed, however. A notable paper was published in 2019 by Casanelli's group, who demonstrated actually that there was a 20% reoperation rate with 28% of patients unsatisfied or very unsatisfied. It is notable, however, that this was a retrospective single surgeon series and the follow-up was relatively short. Furthermore, a significant number of these patients had a steroid injection after their Cartiva, and also different surgical techniques were used as compared to this paper, and learning curve data included. So, in conclusion, at 5.8 years follow-up, the authors have demonstrated that there were significant improvements in functional outcome, which were maintained, and significant improvements in pain, which were maintained. Pre-op range of motion was also maintained, and implant survivorship was 84.9%. The authors therefore conclude that midterm results demonstrated that clinical and safety outcomes of Cartiva are stable, and that the implant remains a viable treatment option to decrease pain, improve function, and maintain motion for patients with moderate to advanced hallux rigidus. Many thanks, and I look forward to hearing Mr. Blundell's thoughts on the paper. Good evening, and thank you for the opportunity to discuss Mr. Blundell's paper on midterm outcomes of a synthetic cartilage. Good evening, and
wait for our screens to show us in full glory, I think, Chris.
Thought we were going to have Shilpa again.
No. Well, thanks for joining us, Chris, from Germany, where you're on your retirement trips. Whilst Rob sorts out the video so we can see ourselves in full HD vision. Thank you for joining us to discuss your paper and thoughts on it, and then have a discussion with Tim in a minute. So how do you feel about the paper now, and how you developed the Cartiva implant and the problems you had in getting it into clinical usage?
Yeah, so it's been a really interesting journey. I think one of the important things is literally the robustness of the accuracy of the data and the statistics behind this paper. And the Cartiva motion study group, as it's called, which was 12 centres, 6 in Canada and 6 in the UK, are a sort of a loose collective of people who were originally brought together by Dishan Singh, actually, who sort of introduced us to one another to be part of this study. And the study was a great study to be involved in, because there was so much data and so much accuracy of data and so much resources behind it. So rather than the sort of studies that, for example, Tim's and Joe's study that we'll hear about, where it's Tim and Joe have had to sweat very, very hard to get that data together, this was easy to do because we had loads and loads of resources behind us. The downside of that is that it was funded by Cartiva themselves. And so, of course, there's immediately criticism always thrown at any industry-funded study that's studying its own implant. And I understand that. And it's the usual argument about, do you want a study that's incredibly robust and tight and multi-centered and real world that ends up having to be funded by someone, or do you try to go it alone? And I would defend the fact that Cartiva did fund it, because there's no other way it ever would have got done. The rationale behind the original study was to get FDA approval for the implant. So that was the original thrust of it. And the FDA are very, very tight on the control of data and the accuracy of data and the acquisition of it. So I think that the figures that Shilpa said there are very true, and it's a very honest, warts and all study. I don't think it's trying to prove anything that isn't there, which is why the results are not that spectacular. They're good, I think, but they're not spectacular. We haven't got sort of 100% survivorship, which you do sometimes hear from designer studies. You hear that they have this outrageously good results, and you think, well, really, I'm not sure I trust that. Whereas I think this data is very, very warts and all. The original 5-year review was pushed hard by me, among others, and I was the PI on the 5-year study in the UK and Mark Glaive's book on the Canadian data. And that was because I felt that the implant was starting to get a bit of mission creep. There was a bit of slide, people talking negatively about it. And I wanted really to make sure that people read the original paper again, because one of the things about this implant is that it takes quite a long time to settle, and it definitely does. If you look at all of the curves of pain and function, the first 6 months it performs less well than a fusion. And you have to see it out to a year before the data starts to assimilate, and then you see that there is no inferiority of the implant versus a fusion. Up to a year, it's inferior to a fusion. And the problem with Casanelli's group and others is that they pulled loads of them out early. I mean, I went head to head with Thordarson, who's the other author on that, at the American Academy, because he stood up at a meeting and said, your implant's rubbish. You know, I've pulled out 1 in 5 of them in the first 6 months. And I just had to say, well, slow down a bit, look at the curves. You know, within the first 6 months, it won't settle like a fusion does because it's moving. And I'd be interested to hear what, you know, Tim hasn't got the multiple data points that this study had. You know, we were looking at pain at 2 weeks and range of motion at 2 weeks, 6 week, 12 week, 3 month, 4 month, 6 months, you know, and so on, because the resources were so great to do that. And so we have this really good understanding of how the implant bears over time. And there's no doubt that between 2 years and 5 years, there was a sustained improvement in those that it survived. Obviously, when it fails and it gets pulled out, and that's, you know, that's how an implant goes. And I'm sure Tim will beat me, as Tim does, about the fact the survivorship of this is not as good as the survivorship data for his implant. That it's not his implant, but the implant that he's you know, researching. I guess the implant doesn't survive so well if you believe these 2 papers to be absolutely true head to head, and the data sets are similar and the timelines are similar. But the recovery, if you do have to take a Cartiva out in terms of converting that to a fusion, is so straightforward. It's literally like doing a primary fusion. So it's, you know, Mark Davies and others presented a paper that was called Don't Burn Any Bridges. And the idea was to say, well, look, okay, if you select your patients really carefully, and the Cartiva works, I believe it works in very carefully selected patients, and that perhaps we'll talk about when we're with Tim together, because I think that's the crux of this. If it works, it's great. But if you get it wrong because you've selected the wrong patient or you've had bad luck, to revise this to a fusion is a very straightforward and simple thing with very good outcomes. We've got evidence that says if you revise a Cartiva to a fusion, it's as good as a primary fusion was in our fusion group. So you've kind of literally lose nothing by doing this. Whereas, you know, I've presented and published before about bone block arthrodesis when you've chopped out a joint and you've got a gap and you want to try and restore first ray length so that you don't get transfer. That's quite complex, and I don't think that's very straightforward, and the outcomes are not all that great. So the sort of burning bridges, that joint replacements that remove the metatarsal and the base of the phalanx, they are burning bridges. So I think that's the big difference really between the Cartiva. Survivorship is not as good as Tim's silastics, but if it fails, and I think it fails in poor selection largely, so I think you can remove that, but I don't have very robust evidence behind that, then you don't burn the bridge.
Excellent.
Yeah.
I think we'll, I mean, I've got a few questions that are brewing in my head to ask you about patient selection and counselling and things like that. I think what we'll do first off is we'll go to Tim's paper, hear the video presentation of that, hear Tim's thoughts on his experience, and then come together for a fireside chat, shall we say.
Sure.
I'll hand over to the video now.
Good evening, everyone. I'm Joe Ring from Bolton, and I've been asked to present the silastic part of the discussion for tonight's journal club, based on this paper written by Mr. Clough and myself and published in Bone and Joint Journal back in 2020. We all know the treatment options for end-stage hallux rigidus that has failed non-surgical treatment. These will include a fusion or replacement, and there's a range of implants available for each of these. In this paper, we discuss the double stem silastic implant. There are a number of papers talking about silastic implants. Unfortunately, it's a bad reputation within the literature. These are usually based on the single stemmed implant, which is now historical, implants implanted with the use of grommets, implants used in the presence of deformity, and other first MTPJ implants, all of which don't have the good results that we see with the double stemmed silastic implant, which we're discussing within this paper. And unfortunately, this has given it quite a bad reputation, which we don't see in our practice. And we want to do a paper to demonstrate this. The aims of the study was to support the functional outcomes of and survivorship of the Wrights Medical first MTP joint double stem silastic implant. And you can see we collected a range of secondary outcomes as well to show the patient satisfaction and the cost effectiveness compared to other implants. This was a retrospective review of a single surgeon consecutive series of Mr. Clough's patients performed at Wrightington. Majority of the patients, as you can see, are female, and the mean age was around in the early 60s. The endpoint of the study for survival was all-cause revision, as with any implant paper. Data on complications and reoperations was collected. A range of PROM scores were collected, including a patient satisfaction score. Range of movement pre and post-opsy was collected and was available in a high percentage of patients, and we formed a pre and post-op radiological assessment. In terms of surgical technique, this is a day case procedure, very much like a first MTP joint fusion. It's performed under tourniquet with a single dose of antibiotics at induction. A standard dorsal approach to the first MTP joint is performed. The joint is excised using a saw blade, and then sequential reaming using the reams supplied on the tray. If you want, trial can be applied to check the size and fit within the joint. And then once happy, the definitive prosthesis can be implanted. The patient can immediate full weight bear in a post-op shoe. We see the patients at 2 weeks for the wound check. And once the wound is healed, they can start gentle range of movement. And as swelling permits, they can return to normal footwear. They're reviewed at 6 weeks, 12 weeks, and 12 months and 24 months as per standard practice. In terms of patient selection, all of these patients had end-stage hallux rigidus that failed non-surgical treatments. The standard cautions and contraindications, as you would with any arthroplasty, small or large joint, are applied. This isn't an implant for patients with deformity, as it has no inbuilt stability within the implant itself, and it shouldn't be used in patients who've got severe inflammatory arthropathy or poor bone quality, as there is a risk of subsidence. And as mentioned previously, we don't use the metal grommets supplied, as we find that the results of these, and there's certainly support of that literature, are worse than if the implant is implanted without the grommets. In terms of follow-up, the mean follow-up was 5.3 years, but we went all the way up to 14.1 years in some of the patients. We lost one patient to follow-up, and one patient died from non-related myocardial infarction. Nearly a third of patients had bilateral surgery on separate occasions, which generally is a good sign that they enjoyed the first procedure. 3 patients in this study required revision surgery. 1 was for a deep infection, which presented with all the signs of infection in the early stages following the procedure. This was revised as a 2-stage procedure with removal of implant, debridement, insertion of a cement spacer, and then a second stage to a blown block fusion. The patient had made an uneventful recovery and overall was satisfied once the second procedure had healed. There were 2 implant fractures, both presented with pain. And as you can see, one was at nearly 10.5 years and one was nearly 13.5 years, both of which were revised to another silastic implant in a 1-stage revision. 2 additional patients required a further procedure. 1 had pain within the joint and was aspirated for infection, but nothing came back on the micro and things settled themselves down with no further treatment. The second one had a manipulation for stiffness, and after that they had a residual arc of 30 degrees and were satisfied. In terms of complications, many of Mr. Clough's papers were very honest with the complications and even present the minor ones for completeness. As you can see, most of these complications were minor and responded to simple treatment. I've included the deep infection and implant fractures, which we have talked about previously. As you can see with all of the others, the treatments were very simple and mostly non-surgical and didn't affect the outcome of the final outcome of the or survival of the implant. No patients in this study had any deep vein thrombosis. In terms of survivorship, we had a 97.2% survivorship at a mean of 5.3 years. Overall patient satisfaction was very high. We report very low complications and low operation rates. And with all this PROM scores, we saw improvements greater than the mean important clinical difference. There was no loosening synovitis or progressive cyst formation seen on the radiographs. There was non-progressive cyst formation in a percentage of patients, but again, this didn't seem to affect the patient outcomes or the survival of the implant, and there was no development of deformity. I'll mention briefly about price versus other implants and fusion. This is a very cost-effective implant. So the overall price does depend on the tariff within your hospital, but when you look closely into this, you find that this implant is very cost-effective when compared to other even standard plating techniques. So in conclusion, the first MTP joint silastic implant is a very safe and reliable implant in this condition. It has low revision rates, low complication and reoperation rates, and it comes at a very competitive cost. The reputation seen in the literature is based on old papers and for other implants. Further studies, obviously like many things in orthopedics, are needed to compare this directly with other treatments and obviously increase the number of patient numbers seen within the literature to try and give us a more evidence-based practice within this area. The take-home message from this is that the silastic first MTP joint arthroplasty with a double-stemmed implant from Wright Medical is an excellent implant with mid-term survival rates, has low complication rates, high patient satisfaction, and it certainly should be considered as a treatment option in end-stage hallux ridges in suitable patients. Thank you.
Hopefully Tim will come into the spotlight now and make some comments on his paper and thoughts about why he wrote it and how he views the implant at the present time. Then we'll have a vigorous discussion with Chris and bring him into the spotlight. Just a few thoughts, Tim?
Okay, so thanks very much for inviting me on this. So several thoughts really is, so number one, you know, my name's batted around with the use of this implant as if it's my implant or I've got a financial interest in this implant. I have zero financial interest and zero conflict of interest in this. So to understand why I did this study is to go back in history. So unfortunately, I'm that old that when I started as a consultant, I was brought up that this is the device of the devil. And, you know, anybody who used it was frankly stupid, and it would lead to catastrophic failure. And that's, as a registrar, how it was presented to us, and that's how it was within the few, you know, literature books that wrote on it. And I accepted that. And then when I took up the consultant post, in my first clinic, I saw two people. I was taken on in a job where you were almost banned from ever discharging patients. You just saw patients just back every 3 years. And that's, you know, the NHS has evolved, and you now have to discharge patients at, you know, as early as possible. And there's no such thing as long follow-up anymore. But in my first clinic, I saw two patients with them, and they'd been in for 10 years. I thought, oh my God, this is going to be great. You know, the patient's going to be limping in. We sat the patient down and I said, how are you? Oh, it's fine. Well, why are you here? Oh, I come back every year. I thought, well, I'll get an x-ray because the x-ray is going to be catastrophic. So I just took out of interest x-rays on them, and they looked okay. And the patients were okay. And I thought, well, that's going to be beginner's luck. And I didn't think any further about it. And then over the next 2 months, I saw 6 other patients. And suddenly I'd seen 8 patients in 2 months. And all 8 were between 5 and 10 years old. And they all said they were very happy with the implant. And then I thought, well, surely there's got to be something into it. So I then started looking into the literature. And I pulled out all the historical papers. And by then I'd inherited somebody's waiting list. And one had appeared on my theatre list, you know, silastic plus MTP joint replacement. I'd never seen one and never done one. And all of these had been put in by the associate specialist when we did have associate specialists who were still there, and must have been 103 at the time, but was still there. So I was like, come on, you got to show me how to do this really difficult operation that must be, you know, catastrophically complicated. And he'd done it in 20 minutes. And I'm not advocating rushing surgery, but I mean, it was unbelievable. And so I kind of closely followed him up at 2 weeks, and at at 8 weeks and then at 3 months. And by then I'd been seeing all these historical ones still drifting through. And by then I'd done 2 myself. And there's no such thing as, there's nothing better than seeing your own patients and following them through. And in answer to Chris's question, this is exactly the same level of pain relief after a hip replacement. At 6 weeks, the patients are delighted. You don't have to wait a year. They're over the surgical wound and they're absolutely delighted, and the toe is pain-free. And I thought, well, there's got to be something into it. So I started pulling out the literature and looked at the evolution. And it started off with Swanson's paper, who obviously had a financial interest and said it was a great thing. And the bad press came in the late 80s and early 90s from America, and there was 4 papers back to back which slated them. And since then, everybody just suddenly stopped using them. But if you go into and pull out those historical papers, they were put in those days, everything wrong with the big toe was a bunion. So they were put in for hallux valgus and hallux rigidus as a mixture. And this is not an implant that we use for hallux valgus. And we don't use it for hallux valgus with OA. Hallux valgus with OA has to be fused, because this has no internal stability. But hallux rigidus is a straight toe, and it works absolutely beautifully. So I just then started using them and just got fantastic results. So then started using them in the private sector, because I had the confidence. The last thing you want when you're doing private practice is to have patients coming back to you, just like in the NHS. So I started using them across both sectors of the system with confidence, and then had done that many that I thought, well, and people kept coming up to me at BOFAS and saying, how are they doing? And I was like saying, well, they seem to be doing great. And they said, well, you need to publish it. So I accept all the criticism of the paper that this is a retro, it's nowhere near as scientific or as intense as Chris's paper, because it's a single surgeon series and it's retrospective, but we've got strong data collection, we've got very few loss to follow up, and we've assessed across a range of functional outcomes. So for me, the good thing on this is if you have hallux rigidus, you can get a great resolution of pain very quickly. The patients are delighted. And if you're looking at survivorship, which the hip and knee boys are, the hip is the best joint replacement in the body at 98% 10-year survival. The knee is probably the second best at about 96% 10-year survival. Well, this is 97 at 5, and it's probably, I tell them, around 90 at 10, which really is the third or fourth best joint replacement in the body. And suddenly, and then when it fails, it's exactly like a hip or a knee replacement. You don't need to worry. All this, I've got to take it out. I don't have enough bone stock. I've got to put a big bone block in, which will never fuse at either end. And it's a difficult operation. Does not need to be entertained, because the vast majority of cases, you can just take it out and put another one in. You can revise it just like you would a hip replacement. And if you do have a little bit of bone loss, then you can fill up that like an ice cream cone with bone graft and remount, and you can get the implant back in. So it's actually a very, very easy revisional operation to do. So I'll leave it at that, but that is the historical reasoning behind it. And it was a case of just see patients, observe what they're saying, and then if that goes against the historical myths of what you've been told, you've got to go back to the literature and drag that out and read those papers carefully and work out why you're seeing a difference.
So do you think it's serendipity that the designs worked? Because would you think you'd be able to get that past ethics and stuff now if you design that implant now?
Well, I didn't design the implant.
I know you didn't. I'm just there's a comment about new implants and
Well, it's not a new implant because it was, you know, I was using it in 1990, well, no, 2003. But I mean, it first came out in 1972.
Yeah, so it's
been out
serendipitous.
30 years.
So I think it's serendipitous. It works so well. If you look
Yeah,
at it,
the people stopped using it in the late 80s and 90s. That's why I was surprised it had been used at that level and intensity, you know, but they were using it. If you go back to all the old historical papers, it was, you know, 30% bunion and 70% hallux rigidus. You know, so what shouldn't you use it for? Well, Joe mentioned it, but, you know, there's nothing like reinforcement. I wouldn't use it for rheumatoid because the bone is too soft. It is not a treatment in any way for hallux valgus with OA, but it is a treatment. And people say, well, how much valgus can I put it in? Well, what you've got to decide is, what is the primary pathology? Is this primary OA, or is this a bunion which has gone on to secondary OA? And once you try and look at those two plates of meat, it's obvious what the primary pathology is. And if it's a bunion that's got now arthritis, then it requires a fusion.
Can we bring Chris into the discussion now, if we can bring Chris in? So what about age for the silastic and Tim? Is that a consideration?
So yeah, that's a common question. Just like, you know, what about age for an ankle joint replacement? It's a joint replacement. So when people show me an X-ray where, you know, the implant's looking pretty horrible, I was like, how long has it been in? I was like, 15 years. I was like, well, let's take a hip replacement and see what the acetabular cup's looking like at 15 years. You know, it's done well, it's survived. So you've got to be sensible. So I would, my lower, you know, there's no such thing as age, it's what their functional and technical demand is. So, but 55, anything below 55, I'd start getting twitchy myself. You know, I think I have put it in 50, but they may just be, you know, a bit of yoga at the gym. They're not going to be a foul runner at 50. You know, he's going to wear it out.
And are you happy to put it in patients who've had previous surgery, like a chilectomy? Is a question from the audience.
Well, so, you know, girthed, you know, so if you've got a primary toe, so that there's no doubt a silastic does well if they've not had, you know, they've not had any, the best operation or the best results would be they've never had an operation on that big toe. If they've had an open chilectomy, I think personally, on the zero evidence, this is just follow-up, results in terms of satisfaction might drop 10%. I'd still do it, it's still good. But so the agony then I've got is, personally, I'm not a great fan of a chilectomy. So if somebody who's 52 who has a bit of OA, you know, grade 3 and has bone spurs, I sit them down and I say, well, look, you know, I could do a chilectomy and you might get 5 or 6 years out of it, but you're looking at 2 operations. Or I can maybe inject it and keep you going with an injection for 2 or 3 years and then do a silastic, and that'll last you more or less forever. You know, so personally, and they usually go down the injection route.
I think Chris is twitching.
Why have 2 when you can have 1? It's not pints of Guinness this good.
So Chris is twitching at the bottom to get in.
Well, a bit, in as much as like I spent about 2 hours this afternoon going through your paper and our paper, actually, and it's really, really interesting comparing the data sets, because the data sets are really, really similar in that you know, your patient's mean age is 61, ours is 58. You know, you've got 108, we've got 106. Your follow-up, your mean follow-up was 5.6, ours is 5.8 years. You know, there's a great deal of heterogeneity in the overall demographics, but the devil is probably in the detail. So, for example, I am a fan of a chilectomy. I do way more chilectomies than I do Cartivas, and I base that really on the clinical evaluation of the patient. I like you, I don't think you believe in X-rays telling you much that's useful to the patient, Tim, and I don't either really. So I remember hearing you say before you thought the Coughlin grading system was a bit useless, and I think it's worse than that. I think it's almost completely useless. So I don't think the radiographic features help to define who I treat with a cheilectomy or a Cartiva. I've done silastics too, and I need to put my arm up here and say I've done silastics. I suspect you haven't done Cartivas, but I have done silastics, and I've got a fairly clear in my mind who I would offer a Cartiva to versus a cheilectomy. So if they've got pain in the grind test, then their joint is damaged, and a cheilectomy for a damaged joint I don't think works, and I suspect you would agree with that.
Yeah.
But I think if they've got dorsal impingement pain but within a functional range, and I load them in the functional range and it doesn't hurt, but if I dorsiflex them to the end of that functional range and they don't like that and it hurts, that patient will get a cheilectomy for me rather than do a Cartiva. And I'm not entirely sure that those patients will ever end up needing a Cartiva or their joints will ever fall apart, because that group of patients, when I do cheilectomies on, they don't seem to come back. Now, I've done Cartivas in 3 patients who have had cheilectomies. So the question we often get asked is, can you do it after a cheilectomy? All 3 of those patients 2 of those patients had minimal invasive cheilectomies by us. So in other words, they'd have the little burr in, and all you do then is just take off the top of the met, the little crescent of the met and the little crescents on the phalanx. You don't take off the sort of 25% of the met head. So I think that's quite a different kind of cheilectomy from the ones where you're removing part of the met head and even a bit of the phalanx, because I think that's really quite destructive. And your experience might be a bit different there again, Tim, because if that's the type of cheilectomy that you would have experienced, then I think you really do burn a bridge then, because if that cheilectomy doesn't work, you're screwed. You've got to do a fusion, because you can't put a silastic in once half the met head's missing, and I can't put a Cartiva in either. So there's there's an iteration that leads between a minimal invasive cheilectomy, which I find pretty good, and if it's not and the joint becomes degenerate, I can do a Cartiva then. Whereas I think you're perhaps a little bit more binary in that you don't like cheilectomy, and therefore you'll do a silastic more readily than perhaps I would do a Cartiva. Does that make some sense? So I guess what I mean is that if you look at the numbers, I was just jotting down here, you've done about 108 silastics over a 14-year period. I presume that your numbers have got greater, not less, over that time frame. So you might be, I don't know how many, but are you doing about 10 to 15 per year?
Yeah, so my numbers are steady and even. So I actually looked it up as well. So I've done 100 so all these are the NHS patients, because we can get hold of them.
Right, so you've done 1,000
I'd actually looked up my privates, and over the 12-year period, I've roughly done about the same. I've done 117 privates. Those ones, so I would see those 2 weeks, 3 months, at a year, get a final X-ray at a year, and then they obviously have to be discharged.
Okay, so you're looking at doing about 250 silastics over a 10 to 15-year period.
Yeah, so it'd be about 10 NHS, 10 private a year.
Right, whereas I've done 56 Cartivas over a 10-year period.
Yeah.
That's public and private. So the numbers that I'm putting them into are way, way less than what you're doing. And the reason I'm mentioning that is you're probably busier than I am, because I'm lazy and I'm retired now. But I didn't used to be lazy, and I suspect that I'm being very, very, very choosy. And you're obviously you've got an interest in this, so patients will come to you. So I don't have a particular interest in forefoot surgery, so patients won't come to me because of their hallux rigidus. It's not a primary area of interest of mine. So I don't think they come my way for this, and it's probably much more universally done across the UK. The problem that we're having, I think, is that the patient selection for the Cartiva isn't good. And I think you're being selective in your patients because you know what you've got and you have your experience. I'm selective in offering Cartivas, but I don't think everyone is. And one of the things that I've always been very keen when I go to meetings and I do promote Cartivas, you've got to choose the winners here. And if you don't, then they'll fail. And unfortunately, that's some of this data set is a very heterogeneous group of, it's 50 surgeons across 12 centres. So it's a very heterogeneous group of surgeons doing, and I don't mean it's not a technical failure, because putting this in and putting a silastic in, there's not a technical element to it. It's pretty hard to put them in wrong, really. I mean, you can, but I think it's amongst our foot and ankle surgery, it's a really straightforward thing. But you can choose the wrong person, and if you choose the wrong person, the implant will fail. And one of the frustrations is that we've got some literature coming out saying the Cartiva is not working. And I can see someone sitting in your shoes in 10 years' time saying, these Cartivas are brilliant. They got a bad press because people put them in badly. And here we've got, and actually, if you choose your patients well, it does really well, which is what you're doing now to silastics 15 years ago. And I'm sort of feeling that there's some literature coming from Castanelli and people like that who have pulled them all out too early, probably, I don't know, but may not have been very choosy about who they put them in. And lo and behold, they don't work.
Who's the winner you choose?
Okay, so you've got to clinically assess them really carefully. So don't put them in someone who doesn't need one. That sounds a bit obvious, but if you can do a cheilectomy, do a cheilectomy. Because your demands after a cheilectomy, you can work very, very well on a cheilectomy. If someone's got a completely rigid first MTP joint, they've got what Coughlin would call a grade 4, but actually it's a nigh on ankylosed joint. They've got that jog of movement. Then don't put a Cartiva in, because it's not replacing the whole joint. Now therein, if they want motion, they're going to have a silastic in my hands, and that would be the group that they get a silastic. So I don't think it's an apples and apples argument, this. So if they're very rigid, I wouldn't do a Cartiva. If they've not got a grind test, which is positive, I wouldn't do a Cartiva. If they've got osteoporosis, I wouldn't do a Cartiva. So those are people with, they're in their 70s, for example. They've got a history of fragility fractures. They've had a very long period of menarche in their lives. That they're on treatment for bisphosphonates, or they're on some sort of treatment, calcitoons. Then I'm worried about that group. So that's why I don't do many of them, because when you chuck out all of these people, you end up with quite a narrow cohort of people who I think would benefit from a Cartiva. And then when you put it in, it works. And I can tell you that out of those 56 that I've done, I've revised 3 over a 10-year period. One wasn't infected, but we thought it might be. One was revised at 5 years, and one was revised at 7 years. So my personal series is actually...
You revised it to a silastic?
I revised all of those to an arthrodesis. Because the reason for that is that because I said to them right at the outset, this is an experiment, right? You're part of an experiment. Then when it fails, I say, look, I don't think we should have something else, which in my hands would be experimental again. And that's just about the conversation, isn't it? I don't think it'd be wrong to do that. I mean, I know you asked the question in jest, but I don't think it'd be wrong to do that, but I haven't.
Yeah. And Tim, if you've done that many, you do, say 20 a year silastics, how many fusions are you doing roughly? What's your proportion? Or is that much like asking an ankle replacement surgeon fusion?
No, not really. So I do fusions. So I can answer that by answering who are going to be your winners for silastic. So your winners for silastic is end stage, hallux rigidus, non-rheumatoid, non-hallux valgus, and women. Women love the silastic more than men. So if you look at that paper, there's 104 women to 4 men, and I have the same conversation with women as I do with men. So I'm not selecting them, but so most men are after a single operation that can almost guarantee pain relief, and they can get into a shoe. Well, that's a fusion, isn't it? A fusion for a man is a brilliant operation. So I might do, in that 10-year period, I might have done as many fusions, but it'll be the reverse. It'll be, 104 men and 4 women.
What about activity levels in an active female?
I don't worry. I don't worry, because
they run
I treat it like a knee replacement. We were brought up doing, hip, knee, and foot and ankle. So I treat it like a knee replacement. So that our peak age is low 60s. They even the active ones, they're not really going to destroy it, because if you put it in the 60, by 6 years to 66, they won't have destroyed it by then. They'll have naturally got tired of running up the fells by then, you know, and, you know, they'll calm down.
I also think that's probably true of the Cartivas, in that those patients who are active, are very active, tend to have pretty good bone biology. And so the implant ends up being reasonably well seated. But I do make sure that they don't do any sport for the first 3 months that's impacting. And the reality is they don't want to anyway, because these things are generally quite uncomfortable. And it is interesting that your patients get going so much quicker than the Cartivas. And I presume that's just to do with the fact that one of them is ablating the whole joint and one of them is not. And also perhaps your patients are much closer to the end of their arthritic period.
Probably, but it literally is. You know, you cut, you know, when you do a hip replacement, you cut the head of the femur out, you know, which is predominantly the arthritic side, and then you replace the acetabular side. Once you got over the surgical pain, the pain relief is then almost instantaneous.
Yeah. Whereas resurfacings are not like that.
Yeah.
So, and I think that, and this isn't resurfacing in that sort of, that's over glorifying what a Cartiva is, but in principle they are similar in that, you know, we are trying to push two arthritic surfaces apart from one another in the manner that a hemi resurfacing would. Because I remember that people talking about resurfacing arthroplasties, you know, that don't recover as fast. So,
I mean, you two are obviously highly experienced and the kind of with big toe arthritis things. Do you think there's going to be many more developments in terms of joint replacement, or do you think this is where we?
No, this isn't the best, you know, model joint replacement for the big toe. Surely it can be improved, but I looked at other joint replacements, and for one of those years in that study, I can't remember, it must have been about 2007. You know, I was like, you know, the literature, everybody's against me. I'm feeling so vulnerable. So I actually played with the hemicap, and for probably 9 months, and I did about 9. And I went over to Holland to see the guy put them in. I was like, well, show me how you put them in. And my outcomes on the hemicap were just, unfortunately, unpredictable and poor. And then, you know, so the first 3 kind of got stiff unpredictably. And I just wasn't happy looking at them in clinic. You know, you see one in hemicap and you think, oh, there's going to be another moaner. And then they said, oh, that's because you're not releasing the soft tissues enough. So I did another 3, you know, basically circumcising the head and releasing every bit of soft tissue, God knows what. And it still just got stiff. And after about 9, I was like, forget this. I'm going back to the, you know, I'm going back to silastic.
Whereas I did do Moj's as a trainee. In Sheffield and in Australia, and then in Australia we did toe fits, and so when I came to the UK, I did 25 toe fits, of which I've actually only revised 1, but they're all part of a long-term review. I've tried to publish it twice without success. 24 of them are still in, but they look shocking on X-ray. The X-rays look awful, which is interesting because the X-rays the Cartiva don't look very magic, and X-ray silastics look pretty ropey too. So all of these implants, well, your paper suggested they did, so I'm only following on that. But you know, it's not the radiographs that matter. And in answer to your question, Ian, I don't know whether this might be it, because the amount of stress that goes across this joint with such a small surface is enormous. And that's why these bonded implants like the Rotaglide, which is the most recent iteration of those, you know, attempts at doing something very clever. The Rotaglide is very clever. And I went to see Håkan Kofed, who designed the Rotaglide over in Copenhagen, and watched him put 2. And they were so complex. You know, it's like a little rotating hinged knee, and it really is a bit over the top. And the results are poor now of those. So it needs to be something that's probably simple rather than complicated, and it doesn't get much more simple than the 2 implants we're talking about here. The sort of chop it out and stick it in, or the drill it out and stick it in approach. They're both very simple. I suspect if you were really critical about the Cartiva and you had a single surgeon series, with good, with a very good understanding of who's put it in, I don't think there's a very great difference between the two. And I will never be a part of anything that demonstrates that because I'm not working anymore. But I'm hoping that someone will do a large single surgeon series. Interestingly, talking about sport, the Withenshaw group, Anand Pillai's group, looked at return to sport infusions versus Cartivas and said there's no real difference in return to sport in those two groups. So, and we all know that people who've had a fusion can return to, reasonably competitive sport if they're not sprint athletes or high jumpers. So,
snooker.
Say again?
Snooker.
Yeah, definitely. Yeah, tiddlywinks and dominoes.
So, just another question about the sesamoid pain. I mean, do either of you two worry about that with either your implants,
massively.
or how do you assess that?
Yeah, I worry about it a great deal. And in fact, if I think there's any sesamoidal irritation, I get a CT and I look at the transverse sections on the CT. And if I think there's any degeneration, they don't get a Cartiva. I think it's quite difficult to clinically demonstrate sesamoid OA, but if they point to the plantar aspect, and if when you dorsiflex them and plantarflex them, you push underneath the sesamoids, it hurts, I'm suspicious. I don't think it's a very good test, but my index of suspicion is there. And if you scan them and there's arthritis, they don't do a Cartiva because it won't work. I suspect the silastic will because you've chopped the joint out.
Yeah, I don't worry about sesamoid pain.
No.
Yeah.
Whereas I worry a lot.
Okay.
But I'm a worrying sort of guy. That's why I had to retire.
Tim's defunctioned the sesamoids, isn't he, by chopping out most of the joint?
Yeah,
exactly. Yeah, it's just a floppy old thing, isn't it? Then.
Yeah. So we're coming to a couple of minutes now before the end of the bout. So I think it's been great hearing you two chat about these implants. I think for me, I still think fusion is great. I haven't done a silastic yet, but I'm always tempted every time I hear Tim talk about it. I think it's about patient selection is the main thing, isn't it?
It's like anything. It is patient selection.
Yeah.
And that's really the take-home message of this: is choose your patient well. You've got good implants. The Cartiva is a slightly different, indication use. It's a different population set. Ours is end stage, ours is just like a hip or a knee replacement. It's end stage arthritis.
And I think the other thing is nice. Both have got a good plan B. I mean, we've all revised some of these. Failing both. I've revised both. I think actually, in the grand scheme of things, they're a straightforward revision. So counselling patients is a fairly easy process now.
I mean, as Tim said, it is good to get it right first time, but you've got to have an eye on the plan B.
And you need to convince insurance companies to fund it as well, which is always interesting with these replacements. I don't know how we're going to. I've had trouble with that. I don't know if you two have had trouble with funding from insurance companies.
No, but then we're special.
Yeah, and I'm just a southwest bone cutter, as we say. So there we go.
I'm afraid that's right, Ian. Sorry.
Yeah, thank you very much. Yeah. So I think we've fulfilled our hour now. So I'd like to thank DJO for sponsoring these sessions. I think done very, very well and helped both us out through difficult times through COVID and continue to sponsor these sessions. If at the end of this, we're going to put up a QR code for the audience. So if you want to scan that in, you'll then be able to get a certificate of attendance for this session. And tomorrow, as long as you give a feedback to the session, or tomorrow you get an email, if you give a feedback through that email, you then get a certificate of attendance for your CPD points from BOFAS. So we'll draw the evening to a close now. So thank you very much for attending, and we'll see you at the next Journal Club or Lecture to Distinction. Thank you very much.
Thank you.
Thanks very much, guys.